morning to everyone. I'm Marian Stolz-Stoicki, and I'm the Dean of Landry College for Women, the Anna Ruth Marquez School, which is this beautiful building that you're in. I'm going to speak about this school very briefly a little bit later, but now I would like to kick off the conference and get us started. And it's my real pleasure to introduce Dr. Alan Kadish, who is the president of Touro College and University System, who, while he's a man who needs no introduction, I just want you to know how important he is to us, the things he's done to move the college forward, to introduce new perspectives on what we do, and to constantly be innovative and creative so that students across the board at our undergraduate and graduate institutions are capable of competing for the best that's out there. We are very, very fortunate to have Dr. Kadish as our leader. I think tonight is Hanukkah, and we think about what leadership means, and it's hard for me to think of a better leader. Dr. Kadish knows I'm always analogizing him to different figures. Today it's Yehuda HaMaccabi, and just in the ability to see the future, to understand what we need, and in complex times to really navigate us in the roles and the opportunities that are there for us, and to see that we can meet those challenges. And now it's my pleasure to introduce Dr. Kadish.
Thank you, Mary. I'm not even sure how to begin to respond to that introduction, so I'll just welcome you all to the conference. The conference on Jewish perspective on reproductive medicine will hopefully deal with a number of current issues that are important for the basic precept that is, of course, the first mitzvah of being fruitful and multiplying. Challenges with reproduction and challenges that can be addressed through modern technology are more common than people who haven't thought about it think. If you include reproductive challenges as well as challenges with genetic diseases and mutations, you're probably talking about 25 or 30% of all families. And that's a challenge which scientific advances have created the opportunity to address. In looking at the field broadly, I think there are three different kinds of questions we have to answer. One is, what can we do? Second question is, what should we do? And the third question is how halachic and moral implications relate to what we should do. Some things that we thought have been settled are actually being challenged by modern scientific advances. For example, dealing with one of the issues that will be discussed today, which is who is the parent when multiple individuals are involved in a reproductive cycle. The issue of surrogate motherhood had been relatively well settled among most halachic authorities, and that is based on the precept that the genetic material determines parentage. So that a surrogate mother, according to most authorities, is a bystander in the birth process, and the parents are actually those who contribute DNA. However, in September, the first study, it's long been noted that you can detect maternal DNA in umbilical cord blood, but it was assumed that that microDNA had no effect on the fetus. However, in September, the first study, relatively well-controlled study, was published, which showed that maternal DNA can not only affect what genes are expressed in the fetus, but can, it appears, occasionally perhaps be incorporated into fetal DNA in microscopic quantities. So the entire paradigm of who is the parent in surrogate motherhood, in my view, will be challenged if this preliminary data is supported by further scientific studies. It's an example of the interaction between reproductive advances and halacha that takes place as scientific knowledge increases. One of the basic principles of trying to apply halacha to modern technology such as this is that halacha has to have, dare I say the word, some degree of plasticity. That is, it has to be able to understand scientific advances, to respond to scientific advances, and occasionally change thinking because of scientific advances. One area where everyone has agreed that this can happen and should happen and has happened is the issue of early or preterm births. In classic halacha, based on science that's 2,000 years old when these principles were first developed, a baby, a fetus at 7 months gestation, 8 months gestation, and 9 months gestation has different halachic status. And as I said, that original halacha that a 7-month fetus is more likely to survive than an 8-month fetus, which has very direct halachic implications for what one can do on Shabbos to intervene in a fetus's survival or baby's survival. That halacha has been rejected by all modern day halachic authorities, and it's very clear that everyone agrees that regardless of the age of conception, once a baby is born, everything must be done to preserve life. What's fascinating is the halachic constructs that have been used to try to justify that change in halacha. And a change in nature, or a combination of a change in nature and scientific advances, has resulted in a change in the normative halacha from a status several hundred years ago where certain preterm infants would not receive maximal life-threatening therapy to the current halachic situation where every baby once born has the status of someone who will live and in whom halachic intervention is required. Those are the kinds of issues which exist in reproductive medicine, and the kinds of issues on mitochondrial transfer and other things that you're going to hear about today from people who actually know what they're talking about, instead of cardiologists who try to think they can dabble in this. So with that introduction, I'll turn it over to John Loike, one of the co-directors of the conference, to begin talking about what's going to happen today. John.
Thank you very much. I want to reiterate a welcome to all of you who came here. This is a very, very exciting conference. And the timing of this couldn't be better, because these new genetic technologies are reverberating into reproductive medicine in ways that we've never before imagined. In 1884 was the first recorded use of artificial insemination in human reproduction. And it took almost 100 years for this transformational technology to take the next step in reproductive medicine, and that has to do with the birth of the first designer baby, Louise Brown, using in vitro fertilization technology. Today, we are engaged in what I call a third wave of revolutionary reproductive medicine. That is, by all these genetic discoveries, we are now able to edit and modify the holy human grail that is our genetic code. And we can do this in very remarkable ways. These discoveries have the potential to correct over 6,000 genetic mutations, errors in our DNA, including diseases that are responsible for Tay-Sachs, cystic fibrosis, Gaucher's disease, certain forms of early Alzheimer's disease, and, of course, certain classes of cancers. However, we're just beginning to understand how this research investigation should be applied to these diseases. And what's hovering over everybody's mind are the ethical considerations of this. Just last week, hundreds of scholars from all over the world gathered together in Washington, D.C. to discuss all these issues at a summit on gene editing. And they issued words of caution that these technologies should not be used to modify human embryos that are intended for the use in reproductive medicine. Listen to the words of the organizers. It would be irresponsible to proceed with any clinical use of germ editing unless and until, 1, the relevant safety and efficiency issues have been resolved, and 2, that there's a broad societal consensus about the appropriateness and the ethics of the proposed application. Let me apply the famous principle of the Ramban to this issue. Ma'aseh avot siman lebanim. The actions of our forefathers serve as signs for their future generations. Every scientist knows that if IVF and vitro fertilization were discovered today and presented today, you'd have huge debates on the ethics and the safety of this technology. The fact that in 1978, Dr. Edwards and Steptoe presented the birth of a cute baby girl to Time magazine established proof of principle that demonstrated that this technology could generate healthy babies. And as a result of this, over 5 million babies have been born using IVF. Today's conference will focus on two technologies: in vitro fertilization and mitochondrial replacement therapy, which is an example of genetic modifications. Many of you know about in vitro fertilizations. Let me just highlight the potential of mitochondrial replacement therapy. There are many women around the world, the United States, Great Britain, who have mutations in their mitochondria. They have errors. And because of that, they are affected with severe symptoms or mild symptoms, but every one of their children they will have the same symptoms and disease. And by using this mitochondrial replacement therapy, you will allow these women to have healthy babies. So let me make a prediction that as soon as mitochondrial replacement therapy or any of these other genetic modifications intervene to actually create a healthy child that has a genetic mutation, and if it goes viral on Twitter and on Facebook, millions of couples with threatening genetic diseases will overcome their bioethical fears and emotions and volunteer to utilize these genetic technologies to have healthy children. This is the landscape today. This is the lesson that we should learn from our history. Ma'aseh avot siman lebanim. That if it works, no matter how it's done, it's going to be virally accepted. And they'll understand the side effects, and they'll either accept the side effects or they won't. How many of you would know if you knew that you had the genetics for early breast cancer or for early Alzheimer's, how many of you would take that chance to have that corrected with these technologies? So today, we've assembled legal, medical, and halachic experts in the field of reproductive medicine to highlight the benefits, the risks, the ethical barriers of IVF and mitochondrial replacement therapy as they apply to the field of reproductive medicine. You will hear from our experts that from a bioethical perspective, Judaism has always recognized the sufferings of the infertile couple and has always taken a lead position to ensure appropriate halachic interventions. We learn from Rachel, our matriarch, the seriousness of infertility, as she declared to Yaakov, "Give me children, otherwise I am dead." In addition, we learn from Rachel the need to engage in potential therapy, as she negotiated with Leah to take the dudaim so she would be fertile. We are privileged with us to have all these speakers. Dr. Susan Lobel, you'll hear more about, Rabbi Tzvi Flam, who's a mashgiach and professor at Lander, Dr. Egley, who's assistant professor from Columbia and New York Stem Cell Foundation, and of course, Rabbi Dr. Moshe Tendler, one of the lead poskim in Senior Yeshiva at Yeshiva University. And they'll address either halachic or the scientific parameters on these topics. In the afternoon, there'll be a panel discussion where you'll have a chance to interact, and we'll be discussing the legal and ethical boundaries of these technologies. Now, this conference, and I'll be brief here, is being hosted by the New York Medical College, Columbia University College of Physicians and Surgeons, and the Lander College for Women. There are so many people to thank in planning and executing this conference. And as I said, I will be brief and recognize that my thanks are more profound than the words that I use. First, my co-chair, Dr. Ira Bedzo, the Director of Biomedical Ethics and Humanities Programs at New York Medical College. He has worked creatively and diligently to plan and to actualize this conference. Credit, of course, has to go to Dr. Alan Kadish, the president of Vitro College and the university system, who is constantly expanding the academic breadth of this amazing university, as well as finding time to teach and to lecture to various students, including those at Lander College for Women. We also acknowledge other key personnel at Turo. Rabbi Moshe Krupka, the Executive Vice President, Dr. Marian Stoltz-Loike, the Dean of LCW and Vice President for Online Learning at Turo, Malka Fleischman, Associate Director, a graduate Jewish program on campus and Turo College system, Julio Rodriguez Rentes, he's Assistant Director of Web Communication in the Office of Public Relations at New York Medical College, Aina Smirnova, who's a lecturer of computer science, and of course, Will Murrow and all his staff who are responsible for the operations at the college here. We also want to thank Alex Cook and Gary Madger, senior engineers at the Orthodox Union, who's been one of our sponsors for this program. The other sponsors are listed in the program, and you're welcome to review them, and we thank them all. And finally, I'd like to thank my students, Basha Berman, Chana Miller, Yael Bree, Mindy Kresh, Tova Dardashti, Maya Levy, and Alyssa Shiner, who are from LCW, Barnard, and Queen College, who have all helped to make this conference a success. Now, let me present to you Dr. Ira Bedzo, who will introduce Dr. Lobel.
Thank you, Dr. Loike. Before I begin, how many people are as excited as I am to get this started already? In order to make sure that we have this first speaker come up as soon as possible, I will give a brief introduction to who she is, so you can be as aware as I am as how capable and how exciting this start to this wonderful day will be. Dr. Susan Lobel graduated summa cum laude from Princeton University and Harvard Medical School. She completed her residency training in obstetrics and gynecology in Brigham and Women's Hospital and Massachusetts General Hospital, and her fellowship in reproductive endocrinology and infertility at Brigham and Women's Hospital and Harvard Medical School. She is board certified both in obstetrics and gynecology and in reproductive endocrinology. She also served on the faculty of Harvard Medical School. She developed and directed the IVF program at Genesis Fertility and Reproductive Medicine before leaving and founding Metropolitan Reproductive Medicine. Dr. Lobel is a member of the American Society for Reproductive Medicine, the American College of Obstetricians and Gynecologists, the Society for Assisted Reproductive Technology, and the American Physicians Fellowship. She has privileges at Lenox Hill Hospital. Internationally known for her expertise, Dr. Lobel has been the recipient of numerous awards for her excellent care and compassion. She has lectured widely and has been interviewed many times on television and radio. And now, without further ado, Dr. Lobel.
Thank you for a very kind introduction, and I very much appreciate the opportunity to be here this morning. So I'd like to start by giving a brief review of in vitro fertilization, and then some questions with regard to halakha and to ethics that are raised by the current technology, which Rabbi Flam will address in the next lecture. As mentioned, the first in vitro baby was born in 1978. The indications were blocked fallopian tubes. The procedure was done using a natural ovulation cycle requiring surgical removal of the egg, or what we call oocyte. The success rate at that time was very low, and in fact, the joke was that more women got pregnant waiting to do IVF than actually doing IVF. And there were a lot of concerns about the potential developmental risks of a baby born through in vitro fertilization. Today, nearly 30 years later, over 5 million children have been born from IVF worldwide. Over 500,000 IVF cycles are done annually worldwide. The indications now include not only tubal occlusion, but ovulatory disorders, endometriosis, uterine factors, sperm factors, unexplained infertility, and more for genetic disorders. The cycles are done with medication and controlled ovarian hyperstimulation. The eggs are extracted with ultrasound rather than surgery, and overall the success rates are very good, and we have a lot of data on the risks both to the mother and to the child. Now, IVF is still based on the natural conception cycle, where for approximately 2 weeks, the brain produces the hormone, follicle-stimulating hormone, that enables an egg to mature. Another hormone is then released, causing the egg to be released from the ovary and picked up by the fallopian tube. The sperm travels into the fallopian tube, and in natural fertilization, in vivo fertilization, the egg and sperm meet in the tube where fertilization occurs, and after 2 to 3 days, the fertilized egg travels down into the uterus, and after another few days, implants in the uterus. With in vitro fertilization, conception occurs in the lab rather than in the fallopian tube. In current technology, in the menstrual cycle before the cycle in which IVF is performed, the natural hormones are suppressed. This can be done with either a GnRH agonist, which is commonly referred to as Lupron, or with using oral contraceptive pills, followed by using another medication, a GnRH antagonist, as the egg matures. After a woman gets her period, she takes follicle-stimulating hormone for approximately 7 to 12 days to cause the egg to mature. The medication dosage is titrated based on her response, and this is measured by measuring estrogen levels and also the development of the follicles, little cysts in which the egg develop on ultrasound. When the eggs are mature, based on the estrogen levels and on the follicles, the ovulation is triggered. The natural hormone is LH hormone, but we commonly use HCG hormone to trigger ovulation. Ovulation will occur 36 hours after the hormone is given, so we schedule the egg retrieval 34 to 36 hours before the retrieval. In other words, we can time when we do the retrieval, so we're not doing it at 2 o'clock in the morning. Today, most procedures are done in a small operating room located within an office, which is adjacent to the laboratory. Intravenous sedation is used, and the retrieval is done with an ultrasound and a needle rather than requiring surgery. And on the picture, this is a cross-section of the uterus, the fallopian tube, and the ovary, and a cross-section of the ovary with the stimulated follicles. And each one of these would contain an egg. And the ultrasound probe is placed in the vagina with a needle attached that goes through the vaginal wall into the ovary, and the follicular fluid is drained, and then that's given to the lab where they can identify the egg. And this is how it looks on ultrasound, and we pass the needle through and drain the fluid. Now, on the same day that the egg is retrieved, the sperm is produced. In most cases, this is done through masturbation. It can also be done with sexual intercourse with a collection condom. And in certain circumstances, we use frozen sperm. For example, if a man has had cancer and froze sperm prior to chemotherapy with various ejaculatory disorders, or if there's a blockage that precludes the sperm from coming out, a needle can be put in to the vessels and the sperm aspirated prior to the day of IVF. And in certain circumstances, while no sperm is produced in the ejaculate, there is sperm in the testicle, and with the urologist biopsying the testicle, sperm can be found that can be used in IVF. Now, for the first number of years with IVF, what was done and what still continues to be done in most cases is that the sperm is obtained, it's processed, and placed in little oil droplets, and an egg is placed in each droplet and allowed to fertilize naturally similar as to what occurs in the fallopian tube. But what was noticed early on, as the indications for IVF were expanded from not just blocked tubes, but for the many circumstances where there's a decrease in the sperm parameters, that in 10% of the time, even when you placed thousands of sperm right next to the egg, no fertilization would occur. And so a technique was developed, intracytoplasmic sperm injection, which we refer to as ICSI, in which a single sperm head is placed inside the egg. And this is conventional IVF with the little droplets and an egg in each droplet. And this is ICSI, where the egg is held and the sperm head directly injected into the egg. Now, this is what an egg looks like on the day that it's obtained. On day 1, we can see 2 pronuclei, and that confirms that there's fertilization. Even when we do ICSI, where we actually put a sperm inside the egg, which you could think of as fertilization, but with IVF, we refer to fertilization when the nuclei join. And not all eggs will fertilize. And while at some level this is frustrating, we feel most of the time this is because there's either an abnormality in the egg or the sperm, and it's nature's way of precluding the development of an abnormal embryo. And this was a major concern in the early days of IVF, that, how would the scientists know which is a normal egg or which is a normal sperm? But fortunately, the checks and balances that nature has remain intact even with IVF intervention. And what we observe in the laboratory is fertilization on day 1. By day 2, the egg should have undergone 1 or 2 divisions, and we have 2 to 4 cells in the embryo. On day 3, with a normally developing embryo, we have 6 to 8 cells. On day 4, there's a rapid increase in division to what we call a morula, which looks like a bunch of grapes. And by day 5 and day 6, the embryo differentiates into a blastocyst. Now, the number of embryos to transfer is predicated on several factors. One is maternal age. That pregnancy rate decreases with maternal age, and also with regard to paternal age. Another important factor is the quality of the embryos. That the scientists look at the embryos and grade them based on factors such as the evenness of the cells, the contact amongst the cells, whether there's fragmentation on the earlier stages, and with blastocysts on other developmental factors. And there's a rough correlation between the quality, how an embryo looks, and whether or not it will implant. It also depends on the number of prior IVF cycles. We're going to put back fewer embryos in someone trying for the first time rather than someone trying for the 4th time. And it's also the risk of multiple gestation. In someone with underlying medical problems such as obesity or increased blood pressure or an abnormality of the uterus, we're going to be much more concerned about multiples. Whereas if someone's been trying for a few years, they most of the time would really want to have twins, although we still have concerns because there are increased risks. And in recent years, there's been a lot of push to decrease the risk for triplets and quadruplets, which we've been successful with. And with the embryo transfer is in some ways more important but less involved than the retrieval. No anesthesia is required, and we take a little catheter with the embryos loaded inside and pass it through the vagina, through the cervix, to approximately a centimeter from the top of the uterus and inject the embryos. Sometimes it goes easily, other times it can be rather tricky to pass the catheter through. We also do this with ultrasound guidance. The early emphasis was on improving embryo quality and improving pregnancy rates. As procedures develop both technically and with the various fluids that are used in the laboratory for embryo development, we obtained more and more extra embryos. And up until fairly recently, we could freeze the embryos, but oftentimes the embryos wouldn't survive freezing, and the pregnancy rate was generally about half of that for frozen embryos than for fresh embryos. But with advances in freezing technology, we currently can freeze embryos so that most embryos survive freezing, and currently the pregnancy rate with frozen embryos is approximately the same as fresh embryos. And so this has opened up a lot of opportunities. It also decreases the pressure for the number of embryos to put back, because we can put back one embryo and freeze the rest, and if someone doesn't get pregnant, we still can be fairly confident that we'll have good embryos for them on another cycle. The pregnancy test is done 14 days after retrieval. Now, even with putting back a very good-looking embryo, not all embryos will implant. Sometimes this can be a technical issue, but most of the time we feel it's because it's not a healthy embryo. And so while it's frustrating, it's a natural block of nature, and in the big picture, it's a good thing. Naturally, 33% of all conceptions end in miscarriage. And again, most of the time this occurs because nature is preventing an abnormal embryo from developing further. And in a classic study that was published in the New England Journal about 20 years ago, it was found that 33% of all natural conceptions end in miscarriage, but 25% of recognized pregnancies. In other words, women not uncommonly will conceive, but the pregnancy just lasts a short time and they won't even realize that they're pregnant. The risk of miscarriage increases with age. And so while the overall rate is 25% of recognized pregnancy, in general, the miscarriage rate is around 15% for women in their early 20s versus 50% for women at age 40. Initially, as mentioned, there was a lot of concern about what IVF babies would look like. Now that we have 5 million of them, we can be reassured that for the most part, IVF babies are like all other babies. There are difficulties in doing studies on IVF babies because the studies are confounded by why the couple is doing IVF. If you have a couple where the husband has a very, very low sperm count, it's more likely that there's some genetic factor in the sperm that can be passed along to the child. But for the most part, when this is taken into consideration, overall it's felt that there is a very small increased risk of birth defects in children from IVF, but this is far outweighed by the benefit of having these children. The ICSI procedure has a very small increase in two disorders called imprinting disorders, but again, overall the chances are very, very small. With IVF, because generally we put back more than one embryo, there is an increased risk of multiple gestation. With going to blastocysts, where the embryos develop further, we are now putting back fewer embryos, and there's been a concerted effort to put back fewer embryos, again, because we have them develop more so we can be more selective, and also with having a better freezing option. So whereas 15 years ago, having triplets from IVF was fairly common, nowadays it's fairly uncommon. Studies have shown, again, there are confounding factors by the underlying fertility problem, that there probably are some increased risks with pregnancy with IVF, but again, most pregnancies end well. Now, IVF has been a tremendous boon and tremendous help for many couples having difficulty conceiving. But more recently, we're doing IVF more and more for couples that have a genetic disease or have the potential to pass the genetic disease on to their children. And this is a very exciting development in our field, and one that we hope will progress further. And this was made possible by the remarkable developments in molecular biology. And it's now at the point where couples can be tested with a blood test to see if they're a carrier for a genetic disease. And we can take a few cells from the embryo and biopsy the embryo and determine if the embryo is a carrier for the disease or affected by the disease. The biopsy is usually done on day 3 or day 5 or 6 of development, and more we're doing this on day 5 or 6 at the blastocyst stage, because the embryo is more developed. There's more unanimity amongst the cells, and it's also felt it's probably less harmful to the embryo biopsying at this stage. So the embryos are formed, they're biopsied, the embryos are frozen, and then the removed cells are tested to see if the disease is present or a carrier for the disease. And we also test the embryo for normal chromosome content, because it wouldn't make sense that if we found an embryo doesn't have Tay-Sachs disease, but it has an extra chromosome 8, then when we would put it back, either it wouldn't implant or the woman would miscarry. So we want to put back an embryo that both is not affected by the disease, but has a normal chromosome content. And so after the embryos are tested, the woman comes back, and on a thaw embryo cycle, we thaw out a healthy embryo and transfer it back, yielding a good pregnancy rate. Now, while the technique was developed for testing for specific genetic diseases, we can also, what we call pre-implantation genetic diagnosis, we can also do pre-implantation genetic screening, where there's no disease present, but we can test the embryos for chromosomal content. Again, the procedure is the same, that the embryos are biopsied, the normal cells, the cells are removed, and the normal embryos are identified, and then just transferring back those with normal chromosomes. Now, this is something that is a field of, or an area of a lot of debate in our field right now, because most abnormal embryos will not implant, or if they implant, they'll miscarry fairly early on. Biopsying the embryos, freezing the embryos, transferring them back adds thousands of dollars to the cost of the procedure. And in many circumstances, it's not necessary. If you have a young patient and you put back a single embryo, most likely it's going to have normal chromosomal content. Or if it doesn't, and then you transfer back a second embryo on a thaw cycle, it's still going to cost you less than going through biopsying the embryo and testing it. On the other hand, if you have a 40-year-old patient who's had several miscarriages, this can be very helpful in increasing the chance of conceiving and decreasing the chance of miscarriage. But it's also important to note that even though an embryo may have chromosomal content, normal chromosomal content, it can still miscarry and can still develop other abnormalities. Now that's an overview of where IVF stands right now. Because IVF is a process that occurs over 2 weeks and involves a woman's menstrual cycle, there are certain issues that develop with regard to Jewish ritual. And when I came to New York, I looked at these issues and set up our program to try to get around as many issues as possible. And my former mentor from Harvard, Dr. Selwyn Oskowitz, dubbed it kosher IVF. So I will leave it to Rabbi Flam to go over the halakha and how significant the various issues are, but our approach was just to avoid them as much as possible. So the first issue was with regard to mikvah, that as I mentioned, that the woman takes takes medication to stimulate the development of the eggs. And generally, this shortens the first part of the cycle from the traditional 14 days to less than that. And so potentially that can be an issue with mikvah. So there's the issue of doing the retrieval before the mikvah, but more importantly, if a couple is producing the sperm sample through intercourse, it's obviously going to be a problem if the retrieval falls before mikvah. Now, this is something that can be easily gotten around with the use of the medication Lupron that I mentioned earlier, that the woman starts the medication about a week before she gets her period, and this stops the brain from producing hormones to stimulate the ovary. So she's in kind of a limbo phase. And theoretically, she could stay on the Lupron for weeks before starting IVF. We don't leave her on Lupron for weeks, but whereas generally people start stimulating the ovaries at around day 3 of the menstrual cycle, we just wait a few days more to start the stimulation, and this will ensure that the retrieval falls after mikvah. Another issue is with Shabbat and holidays. So with regard to holidays, we just don't cycle if the retrieval could possibly fall near a holiday, and also the monitoring. With regard to Shabbat, since that's every week, that's a little bit more complicated to avoid. But again, using the medication Lupron, that we found that if we start the stimulation on Friday or Saturday, given that the stimulation is almost always at least 7 days, that will ensure that the retrieval falls after Shabbat. With regard to monitoring on Shabbat, that to follow the development of the eggs, we usually can monitor the patient about every other day. Sometimes we're required to monitor 2 days in a row, but generally when you have the results from one day, you can pretty much predict what's going to happen over the next 2 days. So in our Jewish patients, we monitor on Friday and Sunday, and that usually will avoid Shabbat. Rarely, if someone's having a very aggressive response, it will be important to monitor them on Shabbat. And what we do is, instead of having them come into our office, practicing in New York, many people live close to a commercial lab, so they can walk to a Quest or a LabCorp. Or if that's not available, the organization A-Time has an arrangement with a gentleman will come to a woman's home and draw her blood and bring it into the lab. But again, fortunately, most of the time we can avoid that. With regard to the embryo transfer, whereas the retrieval can only be done on one day when the eggs are ready, if you have a good embryo, it doesn't matter if you put it back on day 2, day 3, or day 5. The longer the embryos are developed in the lab, the more fall off there is in the development, leaving the embryos that are more likely to implant. And nowadays, we mostly put back embryos on day 5. But if day 5 is Shabbat, we can put the embryos back on day 3. Or if there are only a few embryos and we were going to put them back on day 3, and day 3 is Shabbat, we can put them back on day 2. And having done this many times, we haven't found any compromise in our pregnancy rates. Now, in the laboratory we have various eggs and sperm, and that every reputable lab has a lot of precautions so that the eggs and sperm aren't mixed up. Because if we took someone's kidney and put it in the wrong patient, the body would reject the kidney. But with embryos, if we were to put, there isn't the same rejection process. So if we were to put back the wrong embryo, the body would accept it. And this creates the obvious problem, not being the person's own genetics, but also legally, if you give birth to an embryo, if you give birth to a baby, it's your baby. And so all programs have very strict rules, and the few times where there have been cases of mix-up, if you look back, it's almost always because someone, or I shouldn't say almost, I said every case that I'm aware of, it's because someone in the lab broke the rules. But because of that some authorities feel that you should have hashgacha, where a trained supervisor will be there in the lab and observe the eggs and sperm at all times. And once the eggs and sperm are combined and put in the incubator, we have a separate incubator that's sealed by the mashgicha, and the eggs and sperm are only taken out under the vision of the mashgicha, so that there's a witness that can attest to the fact that the proper eggs and sperm were used. Okay, so now I'd like to raise a few ethical issues for the rabbi to address. With the screening of the embryos, we're able to identify the sex of the embryo. And so couples will come to us sometimes and say, well, we'd like to have a firstborn boy. We don't have any fertility issues, but we want to have a boy. Can we do IVF? Another situation is where a couple is doing IVF for fertility or genetic reasons, and because we're going to screen the chromosomes, we're going to find out which embryo is male and which embryo is female. So in that situation, is the couple able to request a particular sex? It's very common now that through Doria Shurim, certain couples are screened before getting married, but that doesn't screen for all genetic diseases. And before we do IVF, that we screen couples for over 100 genetic diseases. And the issue arises if a couple is a carrier for a disease, are they obligated to do IVF and to prevent their child from having the disease or for being a carrier for the disease? And genetic diseases are generally fall into two categories. Those that are autosomal dominant, where someone will have a good gene and a bad gene, but the bad gene is active. An example of this is Huntington's chorea. So that this is a disease that occurs later in life. So someone's father may unfortunately develop Huntington's chorea. They find out that they're a carrier. And so each of their children will have a 50% chance of inheriting the disease. So is it okay for them to say, okay, well, we'll go with the 50-50 odds, or are they required to do IVF to prevent passing on this deadly disease to their children? Most diseases are recessive. An example of this is Tay-Sachs, where as long as someone has one good gene, the disease won't be manifest in them. But if someone who's a carrier marries another carrier, then their child has a 25% chance of having the disease. And again, with IVF, we can lower the chance to virtually zero. So do they take the odds that most likely the child won't have it, or do they do IVF? Another factor that arises is that now that we have IVF, which has such a good success rate, how quickly should a couple go to IVF? That more than half the time when a couple has difficulty conceiving, it's due to an element of sperm factor. And now that we have ICSI, IVF has a very, very high success rate in couples with a sperm factor. The natural conception rate is 20% per month. In other words, if you have a couple that has normal fertility and they have intercourse at the right time of the month, the chances of conceiving are 20%. So if a couple has a fertility factor, that's going to lower their chances somewhat. So there are situations where a couple may feel, well, we don't want to try for 6 months, let's just go to IVF, where we'll have over a 50% chance per month of conceiving. On the opposite end, there's situations where a couple has a low chance of conceiving, but either for their reasons or for their rabbi's reasons, they delay doing IVF and undergo costs and anxiety when they could conceive much more quickly. So where is the proper line? As I mentioned earlier, that a third of all conceptions end in miscarriage, and particularly for a couple who's had difficulty conceiving, a miscarriage is a very sad event. Sometimes there are underlying factors that we can treat, but most of the time it's a chromosomal factor, and so that most miscarriages, while difficult, are due to factors preventing an abnormal child. If we do IVF with screening the embryos, because we're only putting back embryos with normal chromosomes, we can decrease the chances of miscarriage. It won't totally prevent miscarriage, but there's significant cost. It can be, if someone doesn't have any coverage, when you include the cost of IVF, the cost of the medications, the cost of freezing the embryos, testing the embryos, thawing the embryos, it's around $20,000 per cycle. Also, if you do IVF and create a lot of extra embryos, and a couple gets pregnant and has a healthy child, they now have these extra embryos. So what are they to do next time? Can they try on their own, or are they obligated to use the frozen embryos? And there are situations where if you have, I recently had a patient who was 25 who had conceived easily and unfortunately had 2 miscarriages, both of which were chromosomally abnormal. Now, statistically, in a 25-year-old, the chances of miscarriage are around 15%. And studies have shown that someone in her situation has over a 70% chance of conceiving a good pregnancy. She went to, so I told her, listen, it's unfortunate, but you can be reassured that most likely next time you'll conceive a healthy pregnancy. She went to a different doctor who said, well, you can do IVF, and I would recommend that you do IVF with screening of the embryos, and this way we can put back an embryo that's chromosomally normal, and this will decrease your chance of miscarriage, which was correct, but it was also at a cost of $20,000 and creating the extra embryos. And if you're starting with about a 15% chance of miscarriage, you're really not lowering the chance all that much. Versus if you have a 40-year-old woman who's had 3 miscarriages, she has a much higher chance of miscarriage. So by doing the screening, you're really going to lower her chance of miscarriage. So I hope I've given you an overview of where we stand with standard technology and the questions that have arisen, and I leave it to Rabbi Flam to address the halachic and ethical issues. Do we have time for questions?